Good morning, good evening, all the doctors and the staff, Dr. Stain, Dr. Bernard. Today's topic for discussion is brain death. This is very important topic as a neurologist, or if you are a resident, and a lot of patients, they are in the queue to receive the organs for say for an example CKD, or they have a liver problem or any hand problem or anything. So there are a lot of people who are they're in the queue to receive such kind of organs, and that's why you should know about the brain death as a part of curriculum in neurology residency, and you should know by heart if you are a consultant in neurology. So I'll briefly touch about the brain death. So I will discuss a little bit about the history, definition, and mechanism of brain death, diagnostic criteria, and what are the practice guidelines for determination of brain death, what are the clinical implications of the brain death, and subsequently I'll conclude in 1 or 2 slides. So initially people thought that if somebody would stop breathing, then they are termed as death or dead person. But over a period of time, in few decades later, they realized that heartbeat is also a very important in making the decision whether the patient is still alive or dead. So irreversible cessation of respiration as well as action of the heart would be termed as death of the person. But until that, nobody actually was bothered about the brain death, or the brain was not included. But around 1950s, the time changed and attention was given towards the brain, that if there is certain functions of brain do not work, then permanently the patient will not, it will become irreversible changes and the patient would die. Various terms has been coined in 1959, coma di passi, and first time the brain death was termed or coined in 1965. And since then, a lot of revision in the definition as well as understanding of the brain death had been done. In 1968, in unresponsiveness and lack of receptivity, absence of movements and breathing, absence of brainstem reflexes and coma, whose cause has been identified. So these are all, the definition has been changed over a period of time. 1976, the Royal Medical Colleges, they defined the brain death as complete irreversible loss of brain stem function. So this study of ethical problems in Medline led to UDDA JAMA that was published in 1981. And this particular emphasis was given about the definition of brain death. That is, I would just read it: an individual who have sustained either irreversible cessation of circulatory and respiratory function, or irreversible cessation of all function of the entire brain, that includes brainstem, is dead. A determination of death must be made with the accepted medical standards. Right. So by this time, the people realize that if the brain is dead, then almost 100% possibility that, or rather I would say in the other way, 0% possibility of survival of that patient if he has been declared as brain death. American Academy of Neurology published this practice parameter in 1995, and subsequently it was updated in 2010 with some gathering of more evidences in determining the brain death in adults. That was published in 2010. So what is brain death? Brain death is nothing but irreversible loss of function of the brain, including the brain stem. So this is the definition that was acceptable, which was published in Practice Parameters, and that was published in 1995 Neurology Journal. So what causes the brain death? So I would say any irreversible or reversible process which insults the brain or neurons, that will lead to development of neural injury. And this becomes a vicious cycle. With that, there will be neural swelling, and there will be increase in the intracranial pressure, and subsequently the reduction in the brain flow, intracranial will develop. So whenever there is intracranial pressure is more than that of mean arterial pressure, then it becomes incompatible with the life, and ultimately the brain will stop functioning. So this is the mechanism about the brain death. So what are the diagnostic criteria for clinical diagnosis of the brain death? So there are 3 cardinal features, and there are some prerequisites. I will touch the 3 cardinal features first. Patient should have 1 coma, second, absence of brainstem reflexes, and third one is apnea. That should be positive. So if we are meeting with these 3 criteria, it is almost certain that this patient is brain dead. But however, we should have certain prerequisites before we can jump on making the patient brain dead diagnosis. So what are those? So patient should have acute catastrophic, either in the terms of acute CV stroke, that includes subarachnoid hemorrhage, or massive intracranial space occupying lesion, or encephalitis, or any other condition in which there will be brain death. Then we have to exclude the medical conditions that I will come to later on. But hypothermia is one of the things which we should always consider, or we should exclude the intoxication or poisoning that may resemble initially as a brain death. And hypothermia is one of the things which is prerequisite, that the core body temperature should be more than 90°F. So what are the practical guidelines for determination of the brain death? So here in this, we will evaluate in 4 domains. Like one is clinical evaluation, which is a prerequisite. Then second will be clinical evaluation, that is neurological assessment. More often than not, these 2 conditions or these 2 domains will suffice for making the patient a diagnosis of brain death. Ancillary test may not be required in majority of the patient. However, there are some exceptions to that rule that we will come and discuss in the following sections. And ultimately, you have to document that the patient is brain dead. So what are the prerequisites? So I already told that the insult should be irreversible. Anything which is reversible, please do not entertain any of the discussion of the brain death in either the patient or in front of the relatives, because this timing is very critical to discuss anything about brain death. And there should be irreversible cause of the coma. The body temperature, core temperature, should be more than 36°C. Patient should be having normotension, that systolic blood pressure should be more than 100 millimeter mercury. Now this could be just without any inotropic supports, or it could be with the inotropic support, but the systolic blood pressure should be more than equal to 100 millimeter mercury. And one should have examined at least for the one time for as far as neurology examination is concerned. So how will you assess neurological assessment of the brain death patient? So first thing should be the patient should be comatose. So lack of all evidence of responsiveness to the noxious stimuli. We put the pressure on the sternum or on the supra orbital ridge, and there should not be any eye opening or any movement, or there should be no any motor response other than spinally mediated reflexes. That are some exceptions that I will come in a subsequent slides, that oh, this patient is still moving the legs and you are telling this patient is brain dead, but that could be possible. So be attentive for that. Second should be, one is coma. Second should be absence of brain reflexes. So that should be in the form of either absent pupillary response in both the eyes, or ocular movement on oculocephalic or oculovestibular reflex testing should be absent. Corneal reflexes should be absent, facial muscle movement should be absent, as well as there should not be any pharyngeal or tracheal reflexes. Now you will say that there are some list of the reflexes you are mentioning and how we can diagnose everything. That is not possible practically speaking. But if the sister is suctioning, they do not have any kind of suction reflex or pharyngeal reflex during that period, you can understand that the tracheal reflex could be absent. Now you just have to move the patient's head side by side or up down, and you will see that the doll's eye absent. So that becomes one of the another, and people easily we can discuss. However, it may be a little difficult to do the oculocephalic, that I already discussed. Doll's eye is oculocephalic, but oculovestibular reflex, that could be a little difficult. So what is that? You know the things very well. Cows, you remember, no? Whenever you irrigate any patient or any subject with the normal brainstem, if you irrigate in one ear with the cold saline, it will the eyeballs will deviate towards that side. So that is cause. The C stands so opposite side. So that means if you irrigate with the cold, the eyeball should go to the opposite side, and with the warm water it will come to the same side. But in a patient with brain death, this reflexes will be absent, or there will not be any eye movements with the response to head. So that is, I'm so sorry, I just discussed a little bit about the next slide in the previous one, but this is actually cold caloric test that was I discussing. So oculocephalic reflex is nothing but the doll's eye movement, that you have to move the patient's head side to side, and you can see that there is no movement of eyeball at all. So this is, I already discussed about cold caloric test. Now, third component is apnea. What is apnea? Is nothing but there is a absence of brain breathing drive, right? So how will you make the diagnosis that the patient is brain dead? Now, one should understand that to diagnose a brain dead patient must be there on the ventilatory support. Otherwise, you will never be able to make the diagnosis of brain death. So believe patient is on ventilatory support, and how we can assess that the patient's respiratory is absent. So these are some steps you have to follow, and you will be able to make the diagnosis of brain death by doing the apnea test. So prerequisite that again the patient should have a normal tension, either with or without inotropic support. There should be normal temperature. There should be evolemia. The carbon dioxide level should be normal, that is eupapnea, and there should not be any hypoxia, and there should not be any prior evidence of CO2 retention. If this criteria suffice, then we can go ahead with the apnea test. So you have to adjust the vasopressure according to maintain the systolic blood pressure of more than 100 millimercury. Pre-oxygenate. Now this is the critical step. Now you have to change some setting in the ventilator, that you have to pre-oxygenate for at least 10 minutes with 100% FiO2, then reduce the ventilatory frequency of respiration at least to 10 breaths per minute, and reduce PEEP by 5 centimeter of H2O. And now you have to see that the saturation is still more than 95%, and this is the time when you obtain first ABG. Now you have to disconnect after taking the blood sample for first ABG. You disconnect the patient from ventilator, and you give oxygen via catheter through endotracheal tube, and deliver 100% O2 at the rate of 6 liter per minute. And now you sit down at the edge of the cot tangentially, so that you can look for the respiratory movement. That should be observed for at least 8 to 10 minutes. Now, if there is no respiratory drive, then immediately take the ABG at the end of 8 minutes. And now you compare the PCO2 between the first and the second ABG, what you did. And if your ABG rises to more than 60 millimeter mercury in the second apnea test, or the difference between the two is more than 22 millimeter mercury, then your diagnosis of apnea is positive. So that is known as apnea is positive. If there is any conclusion, we can just repeat after 10 to 15 minutes after stabilizing the patient hemodynamics. Now, when you have to abort doing apnea test, if patient develops hypotension or desaturation, so you can keep on trying time and again with the various maneuvers. So these are the three things. One, the patient should be deeply unconscious. Second, the patient should have absent brain symphylaxis, and third, apnea test should be positive. These are the three things you are sufficient. There is no need of going further with any ancillary test in this particular patient. However, what are the ancillary tests you should know, so that sometime you can utilize those. So what are those? Conventional angiography, EEG, transcranial Doppler, brain scan, and somatosensory evoked potential. So I'll not go into great detail, but I'll just show no intracranial cerebral filling should be there if you do cerebral angiography. However, the external carotid artery should be patent before you do that. So this is the normal digital subsection angiography. You can see the blood is flowing through the vessels and it is reaching up to the cortices. That is normal. But now you can see there is a blockage of the blood is not going at all inside the brain. So that is no intracranial flow. So that is positive test. Now EEG, the prerequisite that you should do at least for 30 minutes recording, and sensitivity should be set at the 2 microwatt. And you can see this is the normal record. You can see alpha waves in the background, and you can see that there is nothing but these are the EKG artifacts that the vertically in the same time interval time lock with the EEG is coming, right? So there is no particular waves you can see over here as compared to this, right? So this is known as electrocerebral silence. Now this should be at the sensitivity of at least 2 microwatt per second. Right. Now, next is TCD. There should not be any diastolic or reverberating flow and small systolic peaks in early systole. So this is the systole and this is diastole, and this is systole. You can see there is nothing in the diastole, right? So there should not be any blood flow in the diastolic or reverberating. Now, what is brain scan? The dynamic nuclear scan that should show no intracranial filling. So that is known as hollow skull scan. You can see that these are the various pictures in which you can see the empty space in the head of the brain of the patient. That is known as hollow skull sign. That means that there is no intracranial filling. And ultimately, SSP is the last one. There should be absence of N20 response in bilateral median nerve stimulation. This is the N20 reflex, and that should be absent in a patient if you want to diagnose the brain death. Right. So these are the ancillary tests. Again, I would repeat that there is no need of going any one of those unless there are some exception to that rule, or if you are unable to make any diagnosis of the brain death, that we will come in the subsequent slide. Now, last thing is the documentation. So how will you document? You have to document the time of the death, brain death. Second apnea test is actually a time of death of the patient. It is not only the time of brain death, but also the death of the patient when your PCO2 reaches to target value. And you can abort also when ancillary test is officially reported, but I'm not seeing. Now you have to fill up the checklist, and then you can contact with the organ procurement organization. More or less, the brain death diagnostic criteria is same in the children. You can see that the patient should be deeply comatose, there should be absence of the brainstem reflexes, and the patient should not be any hypothermic or hypotensive, and should not be having any movement of the limbs except for that of spinal cord level. And this is something which is important in pediatric age group. If your age of the child is 7 days to 2 months, then you should examine twice, and EEG should be at least 48 hours apart. Now, one thing I forgot to mention about the brain death is that one single brain death apnea test is not sufficient. You have to repeat apnea test after 6 hours in adult. Now, in pediatric patient, these are different. Like you have to do 2 examination and EEG 48 hours apart. That means apnea test will do 48 hours apart. If the age of the child is 2 months to 1 year, 2 examination EEG 24-hour apart, or any other ancillary test, then that rule can change a little bit. More than 1 year, 2 examinations 12 to 24-hour apart, and EEG or isotope scanning is optional. Right. So after 1 year, any of the ancillary test or EEG is not required, or it is not mandatory. So this is the same I discussed in the last slide. These are little bit difference between the newborn to 2 months, 2 months to 1 year, and more than 1 year that I already just discussed. Now, what are the pitfalls in the diagnosis of brain death? So if the patient is having severe facial trauma, then we will not be able to examine the pupillary reflex or corneal reflex, or if there is a existing pupillary abnormality, then the test that we discussed for brain death or brainstem reflexes may not be that valid, or will not be able to do it that confidence level, right? So these are the patient in which you will require ancillary tests, say for an example, EEG or TCD or anything else, right? Or if there is a toxic level of various drugs, or if the patient is having disease with chronic CO2 retention, say for example COPD, in such of the patient you may not do apnea test very thoroughly, because already your CO2 level will be raised before you do first apnea test. So in this case you can go through the ancillary test. So these are the importance of the ancillary tests. Now, when you diagnose the patient with the brainstem, you will see there are certain movements which are going on. Whether that movement should be counted or discounted for the making the diagnosis of brainstem, that you should know. So any spontaneous movements which is arising from the spinal cord, or respiration like movement, not actual respiration, but you can see sometimes the aorta pulsations, right? So that may seem like respiration movement or respiratory like movement, that are actually not respiration. Any sweating, blushing, or tachycardia should not be counted. Even if the patient is having normal blood pressure or hypertension, you should confidently able to diagnose the brainstem. Even if the patient does not have any diabetes insipidus, still you can diagnose. If your DTR is still present, or abdominal reflex is still present, triple reflex is still present, or Babinski sign still present, still you can diagnose the patient, because these are all mediated by your spinal cord. So we are discussing about the brain death, and that does not include spinal cord death, right? That you have to remember. So brain death is ultimate death. So I will include few of the questions. Anybody can opt. How can we differentiate locked-in syndrome from the brain death, right? So you, if you have seen any of the patient with locked-in syndrome, then probably you will be able to give the answer. So in a locked-in state, is there anybody who can volunteer to answer this? Okay, so I'll give the answer. So locked-in state is phenomenon in which patients will be quadriplegic, as well as there won't be any lower cranial nerve in signs would be absent, right? Only possible movement will be vertical eye movement of the patient will be still possible, and the eye blinking will be possible. Patient would be fully conscious. If you ask him to close the eye, he will be able to close the eye. However, he will not be communicated further apart from that. So sometimes you may feel that the patient is deeply unconscious, but no, you should look in for the locked-in syndrome. Likewise, vegetative or persistent vegetative state patient will still have some kind of ongoing respiration or little bit sign of the doll's eye movement or something like that. You should not diagnose such patient to have a brain death. So why this brain death? Why you want to declare any person a brain dead? So there are two major implications. One is withdrawal of the life support, and two is organ transplantation. So why brain death? I told you earlier that there is 0% possibility. Hello. So there is a 0% possibility that this patient will survive once the patient has been labeled as brain dead, right? So this will help the relative to withdraw the life support. So after once the brain death is declared, you do not have to give a lot of injections or hi-fi treatment, and you can counsel the patient's relative. Even if they are not willing for organ donation, you can still counsel them to withdraw the support, so that the resources of the hospital can be saved and can be utilized any other patient. So these are all legal in like certain territories on Australia, China, Sweden, Switzerland, Netherlands, Belgium, or some of the states in USA. However, it is still illegal in large part of USA, Australia, Canada, UK, New Zealand. So it's very critical situation. You cannot ask any relatives to take away the ventilator. He would tell, okay, my heart is still pumping, my relative's heart is still pumping. Why should I take away the ventilator, and I just want to continue? So there is no legal rule as far as my country is concerned, India, that we cannot take away the ventilator. Second implication is organ transplant. I already discussed that there are a lot of patients, they are in the queue to receive the cadaveric organs so that their life can be changed. And believe in me, it's really dramatic things you are doing. In last 6 months, our hospital itself has declared 31 brain death, and the last was couple of days before. I am one of the faculty involved in making the diagnosis of brain death. So I keep on receiving the calls for, okay, you come and declare this patient brain dead, right? So we understand the implication, and it's like it's nothing better you can do for the society. Not talking myself, but I'm talking from the patient's relative, that they are donating the organs, which is like one of the wonderful things that can be done in their life, right? So uh, uh, so ultimately the organ transplantation will involve the organ procure team. Dilemma is still there, whether we have to stop all the care once the patient is brain dead declaration, or is there any erroneous definition. But they have come out the permanent solution that the once the diagnosis of death is made under the new definition, the patient is for all intents and purposes is considered as death, right? So second apnea test is actual time for death, and patients relative can go for organ donation. So who are all should be required, one neurophysician or one neurosurgeon, the hospital administrative person, and treating physician. So sign of at least 4 person is required for the patients making the diagnosis of brain death. So ultimately, I discuss everything that we are encouraging the organ procurement for the transplant in recipient. So this is all about brain death. Steps for diagnosing brain death, I will just discuss. It's a series of careful neurological examination. You have to establish the irreversible cause of coma. You understand that it is irreversible thing, then only you proceed with the making the diagnosis of brain death. And you just have to be cautious about and you should be knowledgeable about any of the misleading neurological signs that may deter you to give the diagnosis of brain stem. You have to just put aside the confounding factors, and certain things you should look for the images, and everything should be ready. If you are making the, say for an example, if the patient is telling, okay, it's got intracranial parenchymal hemorrhage, so you have to yourself look for the CT scan, right? So that you can make the diagnosis of the brain death. Any of the confirmatory laboratory tests that may deem necessary, you should go ahead with that. So it's solely clinical, except in certain circumstances that I already discussed, say for an example, facial trauma or any disorder which involves the pupils, age-related differences in the duration of the neurological assessment you have to keep in the mind, and certain people will require, especially the neonates, will require ancillary tests to document brain death, and withdrawal of the life support or organ donation following brain death. They are entertained with legal, ethical, religious, and philosophical issues. Thank you. Thank you for listening and bearing me. So I've got some questions if you want to opt. So following is rather unusual finding in brain death patient. What is your guess? Hypothermia, high blood pressure. I'm talking rather usual finding, not unusual, right? Hypothermia, high blood pressure, diabetes insipidus, or Babinski sign. Anybody wants to attempt? Okay, so it's diabetes insipidus, right? What is the minimum observation period to ensure permanent cessation of brain stem function? So we do apnea test twice, 6 months up, 6 hours apart. So the answer should be 6 hours in adult patient. And determination of the brain death in neonate is done with what duration? 2 examination 24 hours apart. I'm talking about neonates, so 7 or 0 day to 2 months. So that is 48 hours, right? Thank you so much for careful listening. Thank you.